Hello, my name is Sue Bednar, and I'm a graduate of the Loyola DMP class of 2020. My presentation today involves fall risk assessment in the emergency department. Every 11 seconds, an older adult is treated in an ED for a fall, and every 19 minutes, an older adult will die because of a fall. Falls are the leading cause of injuries among older adults and cost more than $31 billion in Medicare costs. We know that older patients who fall experience a readmission rate of 44% within that next year and a mortality rate of up to 33%. This is a serious problem, and the ED literature confirms this. Falling is the most common cause of traumatic injury in geriatric emergency patients. The purpose of this project was to implement a multidisciplinary fall risk reduction program in the Glenbrook Emergency Department. I chose the Glenbrook ED because Glenbrook has the highest percentage of patients 65 and older in the system, and the ED fall rate there increased 10% between 2017 and 2018. Before we move forward, a word or two about context is important. Geriatric patients fall in many places: inpatient, outpatient, at home, and yes, they sometimes fall in the ED. Yet a visit to the ED provides an important opportunity to use a wide-angle lens with fall risk assessment. Did a fall bring them to the ED? Are they taking medications that affect fall risk? Is their home environment safe? These are important questions to consider regarding fall risk assessment in the ED. I chose the Schmidt Fall Risk Assessment tool because it has established reliability and validity, and though it's an older tool, the fall risk factors that comprise the tool can be found in the majority of both ED and inpatient fall risk assessment tools. It's also well supported with level 2 and level 3 evidence in the literature. I utilize Graham's knowledge to action theory because it incorporates that wide angle view of fall risk that I think is so important. The education prior to the project implementation included multidisciplinary online geriatric fall risk education and then PCT hourly rounding sessions. These were live sessions. So as patients presented to the ED, the Schmidt scale was completed by the RN at triage. If patients were identified as a high fall risk, an alert in the form of a red dot appeared in the EMR. The patient was then escorted to a room by the PCT and hourly rounding began. Later, if a patient received a high-risk medication during their ED course, the nurse was then asked to complete the Schmidt scale at that time as well. In terms of the outcomes, I had 92% compliance with the fall risk education on DevelopU and the live PCT education, and I expected that that would be high. Then the pandemic hit in February of 2020, and it certainly affected the conduct of my project. With the wise guidance of my advisors for data analysis, I decided to split the data into two groups, pre-COVID and post-COVID. I had a few interesting findings. Despite a 50% reduction in ED volume between the first month and the last 2 months, Schmidt scale completion rate decreased from 37% to 31%, and I did not expect that. In a follow-up survey, the EDRNs commented that though the tool was very important and it provided great information, it was too complex to be completed at triage. So placement of the scale within the workflow was very important. The second thing, visitor restrictions with COVID made completion of the tool difficult. In normal times, caretakers and family members were welcomed into the triage area and the treatment area. It helped us fill in the gaps with information. With visitor restrictions with COVID, it made it near impossible, right? The second thing, despite a 50% decreased volume, the percentage of PCT rounding dropped from 64% in the first month to 55% in the second 2 months. And again, a follow-up survey revealed some things that I should have thought about. COVID was in full force by that point, and there was actually, rounding was discouraged by the PCTs to decrease their risk of exposure and also to conserve that PPE that everybody was looking for at that time. Finally, the Schmidt scale completion after receiving a high-risk med in the ED. What I can tell you is that during the conduct of the project, about 328 high-risk meds were given to patients age 65 and older in the ED, and only 13% of those folks had a completed fall risk assessment. The point being, many of the meds we give in the ED increase fall risk. So my recommendations include thoughtful placement of the fall risk assessment tool on the ED workflow, and that frontline input is essential. Also, the Schmidt Fall Risk Scale risk scale, though it's reliable and valid, it doesn't incorporate the 2019 Beers criteria, which is an evidence-based list that identifies high fall risk medications in older adults. You have to use a wide-angle lens in attempting to address fall risk in the ED. The patients age 65 and older are the fastest growing segment of the population, and EDs aren't ready for this. Also, and finally, projects that involve information technology always take more time than you think. Thank you for your time and attention to this presentation.